The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon. I'm the Clinical Quality Manager for the National Center for Health in Public Housing, a project of North American Management. I want to welcome and thank you all for attending today's webinar, ICD 10 Resources, Revenue Cycle Management, and Tools You Can Use. This webinar is being recorded and the resources, slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, there will be a question and answer session. I would like to thank HRSA for allowing us to make this webinar possible. Also, we would like to ask all attendees to please complete the survey at the end of the webinar. Your responses help us improve our training sessions. I'd like to get started and talk about a little bit about the National Center for Health in Public Housing. This is a project of North American Management and is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services under grant number U30CS09734. The mission of the National Center for Health in Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health centers grantees by providing training and a range of technical assistance. And now I would like to introduce our speaker for today's webinar, David Wagner. David has been a management consultant to physicians since 1985. He is skilled at all aspects of running medical practices, specifically FQHCs and RHCs. He has run practices of all sizes, from single practitioner practices to multi-specialty, multi-service line FQHC systems. He is skilled in optometry, pharmacy, primary care, dentistry, and behavioral health, along with the specialties generally seen in FQHCs and RHCs. He is knowledgeable on 340B operations, whether they be in-house or contracted to outside pharmacies. David earned his master's in healthcare management, summa cum laude, from the University of New Orleans. He completed his undergrad in international business and finance at Loyola University in New Orleans. David handles strategic planning, board training and review, CEO training and review, as well as general strategic programs for the group's client. He also acts as CFO in the shared CFO system and handles all aspects of HRSA financial and operational reporting, including UDS. Without further ado, I would like to turn the presentation over to David. Good afternoon, David.
Good afternoon, everyone, and thank you for that introduction. Welcome, everybody. I think this is a topic that is near and dear to my heart because I'm not only a CFO, I'm a COO, and other than all of the good work we do around quality, sustainability to me is the next most important piece. And the revenue cycle is actually that sustainability for our health centers. All of you went through the ICD-10 transformation in October, and I think this is a very timely topic because you may not have experienced any hiccups in payments or any hiccups in the system when it transferred to the ICD-10. However, remember that with CMS at least we've got a 1 year would you call it a getting acquainted period? So in October of 2016, you may start seeing some denials that you didn't otherwise have. So today's talk is to show you where those things, where ICD-10 is important in the revenue cycle. We're of course going to review the revenue cycle, and we're going to discuss some tools you can use, key performance indicators to make sure you're staying on track with the implementation. So first of all, let me talk about a couple of acronyms and definitions. Of course, this is for community health centers, lookalikes, which are the 330 grantees, and then those that just receive the enhanced funding. In-scope services, basically that's anything you have on table 5, any services you do required, additional, as well as your locations. And important today is the revenue cycle. That's pretty much, if you can imagine, the flow of that patient dollar from the time they make their appointment and you're able to make sure you're going to receive that dollar from the activities you're going to perform for that patient all the way through to when it actually gets put in the bank. And that's the actual revenue cycle itself. We're going to talk about pieces of that today. Of course, the Uniform Data System Report, UDS, that all of us know and love, is another piece that is can be significantly impacted by ICD-10, and we're going to talk about that. And then just basically the payment mechanisms that we enjoy as health centers, the PPS, Prospective Payment System, and then the wraparound payments you should be getting on any managed care business that you have in your organization. And last but not least, HCPCS CPT, those are the coding codes that we use for the procedures themselves, and then ICD-10 is actually the new diagnosis coding that we're going to be talking about today. So if we could, I'd like to poll to see just how many in the group actually had any kind of payment bottleneck whatsoever in the first couple of months of this year, or perhaps in October, November of last year. Can we put the poll up? And all right, we'll wait for that to come in.
We are currently polling with 65% of the attendees responding thus far.
Okay. And I'm not seeing the result. How's it look? Did everybody have trouble, or?
It looks like around a third had trouble.
A third, okay. So that's a good thing that you didn't experience the bottlenecks, but just keep very, very squarely in your mind that we did have that flexibility from CMS for a one-year period where at least Medicare is not enforcing the CPT and ICD-10 matching. So it's very important that we're going to still go through these steps, even though a great number of you sounds like didn't experience a slowdown.
So I'm going to close the poll in about 10 more seconds. If you haven't answered yet, we still have about 25% of you that haven't answered.
Okay.
All right. I'm going to close and then share the poll.
Okay,
you
good.
Can see the result?
Yep. So most of you guys didn't have a slowdown. That's excellent. But again, we're going to talk about a few points in the revenue cycle where you actually could have that going forward after October of 2016. And we're going to talk about some things you can do to make sure that doesn't happen to you. Okay, thanks. Okay, so let's go through the revenue cycle, and I wanted you to see the green arrows. These are the points that I'm going to stop and really talk about in detail, because these are the points where ICD-10 has an impact. You've got the front end, which is basically making the appointments, getting ready for the visit, things of that nature, the actual visit and the documentation of that visit. Coding, so you're going to make sure you capture all your charges, but the coding itself is where ICD-10 has the impact. Charge entry is another one because some systems actually already have matching crosswalks programmed into them, where if the correct codes are not entered, it gums up your works and it stops at that point, and you can't get the charges actually ready for submission. And then, of course, claims transmission and posting really don't directly have anything to do with ICD-10, but the denial management, when you start getting those denials, that's where it kicks in again. And then, of course, working accounts receivable. So let's talk about the front end. This is one of the pieces that some people have problems with, depending on how your eligibility verification works. The pre-visit, a lot of systems, you must have a reason for the visit, and that's actually coded in your schedule. Some of the systems make that the primary reason for visit in the accounting records, in the billing records, and in the actual visit. So this is the first place where it's critical that you've got the correct code and the most specific code for that patient's complaint coded. The eligibility verification, then, some managed care payers will actually look at the eligibility depending on the ICD-10, primarily around wellness visits and things of that nature. It's not to say that you won't get a response, but you may not get the perfect response if this is not set properly right from the get-go. The next part, of course, is patient registration. You just complete the paperwork, get the insurance card, but when you revalidate that eligibility, you want to make sure that you've now got the exact reason for the visit in the system in case one of your insurance payers uses that ICD-10 to give that eligibility feedback certificate. Then, of course, the biggest one that everybody recognizes is the visit documentation. I'm going to go into a little bit in the next few slides. This is not a coding seminar, so it's not meant to show you, for example, for a diabetic that's coming for their checkup and they've been in control, I'm not going to really talk to exactly the diagnosis codes you need to use there. I do have some resources we're going to give you, and if people need some additional information around that, we could absolutely put something together for you from that regard. But what this is really is the points of the revenue cycle and important things to be cognizant of, as well as how we're going to check ourselves to make sure that we're doing a good job at this. So I just want to make sure everybody understands that. But of course, all of that being said, it's very important that the diagnosis that the provider comes up with, as well as any treatment plans or physical exams, are coded properly. Examples of making sure you code properly whether the patient has that they smoke or that they have any kind of drug abuse problems or substance abuse issues, anything of that nature, needs to be coded very carefully, because now the specificity, as you all know, is extreme. Before it was more general. Now it almost gets to the level, not quite, but almost, of exactly what that patient has on that data service. But so just you need to get to the most specific level possible. And then the charge capture piece doesn't really get the ICD-10 specifically, but this is just a reminder. Make sure people are capturing their charges and capturing all of the charges properly in your system to make sure that you're getting the best results and the best reporting for UDS. The next one that does have an effect is coding. So a lot of the computer systems will actually begin with the medical record, and the doctor or the nurse practitioner or the dentist, the provider, would actually code their level of care, put in the diagnosis coding, things of that nature. But at this point of the cycle, this is where one of your team members that's knowledgeable in coding actually stops, looks, reviews what's sitting in the charge entry system to make sure that this is the matching piece of this that is so critical. A lot of times they'll look at the medical record or the note for that date and make sure that the coding is specific. A lot of times they'll catch errors like an A1C was done during a wellness visit on a diabetic, but was that because of the wellness visit or was that because of the diagnosis of diabetes? It's really critical to match up at this point. And again, this is where CMS has kind of given us a little bit of an okay, or they're not going to, they haven't been really tightening down yet as tight as they're going to go with regard to making sure these specific code matches are proper. Another thing that's critical here, I'm going to stop and talk UDS for 5 seconds. I don't know if any of you guys experienced any kind of UDS issues this time. We're going to have a poll on that in a second. But the way that this matches will be what populates the UDS report properly. And maybe we should go ahead and stop there. Can we do a poll? If anybody had any problems with UDS for 2015 that they did this year, in early January and February. And problems could have been things like, oh my gosh, I thought I had more diabetics than I did, or asthma is another big one. You know, some of the mappings of the asthma measure, of course they all changed because they included both ICD-9 and ICD-10. You could have had issues on your table 6A where you thought you treated more people for certain diagnoses and you didn't. So any of those things can be issues. Can we have a show of who might not have had issues?
So we've got 60% of the attendees have voted so far. So give yourselves about 20 more seconds and then I'll show the results.
Okay, so some of you guys did have some issues, it looks like. And I have to tell you, a lot of health centers experienced this and had to drop back to a 70-chart random audit. But the scary part about it was a lot of the issues had to do with the universe, establishing the actual universe on Table 6B, because it could have missed some patients. So I'm just going to make a very strong recommendation that as you're getting better and better at coding and matching these codes, you're also going to look to make sure your crosswalks inside of your UDS system are working properly. So we'll get to that in a second as well. So the next place that the ICD-10 transition actually has a big impact is the charge entries. So we talked about coding before, which is where someone was actually trying to match up the codes together to make sure they were correct. Charge entry adds another aspect to it. Are things in the right order? Are they appropriate to the insurance plan that's being billed? This is where the staff actually clicks the post button, if you will, to say and capture the visit with regard to HCPC, CPT, and ICD diagnosis coding. So there again, you may have people, a different set of eyes looking at it to make sure that things are working properly for that specific visit and that specific insurance plan to be billed. Then you have claims transmission. So this is really not, we don't have an impact of ICD-10 other than this is where you're going to see the impacts of all the errors. So it's not an issue where we have to properly use ICD-10. This is where we're going to start seeing some of the issues. And I know a lot of the clients that I have that submit through the major clearinghouses were thankful enough to get back some pairing code incorrect notices. Again, they may not have been denials at this point, but a lot of feedback has been coming back talking about that these are maybe not the most specific or they're just not even correct. Some insurance plans, however, were already starting to deny. So that's the first step you'll know. And then, of course, payment posting is another one. As we move further along the payment to performance, instead of paying for instances, now we're going to be paid for the global performance. You may start seeing some payments reduced or denied erroneously due to the mismatches that we've been talking about. So I'd like to take one last poll. Did anybody experience any claims denials due to diagnosis coding? And at this point, I'd like to even invite those who were lucky enough to get the feedback that maybe weren't necessarily denials, but they came back as recommendations or potential future denials messaging. Please let us know about that as well. Or if you had any kind of eligibility issues that in the transition, meaning your eligibility engine stopped functioning. Can we see how many people may have had those?
All right, again, we've got about 65% have responded. Take another 15 minutes, and then we'll close the poll. 15 seconds, sorry.
So it looks like some of you did actually experience these denials. Okay, and it's great that some of you didn't. Again, I would really highly recommend that you take care to go through the next few steps of things that we're going to talk through to ensure that you didn't have the denials just because they weren't being tracked yet. So just take very care with that. So the next part of it is, let's say you did have some denials. The next portion of the revenue cycle is denial management, where not only do we fix the denials, we actually track them, we monitor them, we apply metrics to them to make sure that we're performing at the level that we have established within our own FQHC, RHC, or lookalike, or other health center, and make sure that we're watching these things against, because denial management can quickly get out of control. So the major pieces that you can look at: the front-end processing denials, charge capture denials, coding denials, claims processing denials. We're going to talk about some metrics that you may be able to use to identify where in your revenue cycle you're having these issues. So front-end processing denials, a couple of metrics that are examples are the inability to get an eligibility certificate, and then once an ICD 10 code is corrected, the eligibility just processes without a hitch. That one's a little bit trickier to capture automatically, but you can generally monitor it if you're seeing certain insurance companies that have a lot of difficulty in sending your eligibility certificates back. Charge capture denials and coding denials. Capture denials are things that you're going to see shifts in utilization of services from one period to the next. Coding denials are actually going to be the claims rejections that you'll see on your claims denials reports, and those would be evident basically from, again, certain diagnosis groupings or chronic condition patient groupings that you can sense, along with, of course, the actual denial codes of inappropriate ICD-10 code. But again, you may not be seeing those yet. And then last but not least, claims processing denials. That's where you can actually see before the claim actually gets into the managed care plan or to CMS, where it's scrubbed prior to that, you'll be able to see those denials at that point. So let's move on then. Working accounts receivable. This is the final step in ICD-10 denials, because as you're working your accounts receivable for claims that have not even been responded to, it's very likely that some of these are the same ICD-10 to CPT HCPCS matching that are the issue. So what is the answer to all of this? We've kind of talked about the revenue cycle and where ICD-10 has its major impacts on us. Some highly performing health centers use what we call a 360 audit. This is basically akin to the way many of you are doing already your peer review auditing, where you look specifically only at the medical portion of the visit and only specifically from the perspective of whether or not the provider gave appropriate service and documented appropriately. Right? So that's your peer review that you use in your privileging and reprivileging. Well, some health centers have decided, no, we're going to go end to end, and we're going to use this same 5 patient encounters and start at the beginning of the revenue cycle and go all the way through to the end of the revenue cycle. These audits include financial, operational, and provider perspectives, and they will double as your peer review, because then you would still just take the piece of it out for that provider as far as the peer review for privileging, reprivileging. And we're going to talk about that in a little bit more detail with some of these metrics. So just to very quickly review, remember the PPS system. We've had a couple of updates in February 2016, there was just a little bit of clarification that came out surrounding the use of G-codes. Remember, you have to match your G-codes for wellness visits to the appropriate wellness ICD-10 codes, just like you have to do your diagnostic testing and the evaluation and management services for a non-wellness type exam. And if anyone needs the codes, these are all of the G codes that we're using, or I shouldn't say all, these are the most prevalent codes that are used for PPS billing. And it's also important to note that the proper matching of coding is critical if there's some sort of subsequent illness or injury, if there's a mental health visit. Be careful with coding as the same day as an illness exam, because as an example, a lot of the providers would code a depression code on the exam with the physician, and then the patient goes for a counseling session with the LCSW or some medication management with the psychiatrist. If the patient was there for diabetes and hypertension and had depression as a secondary complicating factor, it's important to make sure you code them in the right order and using the exact coding to the most specific coding convention on the visit, but leave the additional coding of some of the depression and other mental health issues that the patient may be experiencing for the psychiatrist. This is more important for the managed Medicare and managed Medicaid and your managed care plans, but it still can have an effect on the payments in the PPS system. And then just remember, some of these, you still need to code a lot of these types of services that you're providing, but they don't necessarily get paid outside of the PPS rate, but a lot of the work we do is captured for UDS reporting, so we do need to make sure that we're coding everything even if we're not going to be paid for it. So let's move into assessment. So how can we tell that we're doing well, especially in the face of what I said earlier, that CMS is still kind of letting us slide a little bit on some of these things? Well, let's assess your health center. Let's assess the ICD-10 implementation at your health center. CMS put together a fantastic packet called Next Steps for Providers, Assessment and Maintenance Toolkit. I've got the link for you guys further down in the webinar. But this is actually a simple process of adding financial and operational key performance indicators that are part of the revenue cycle and beyond into your quality assurance, quality improvement program, your QA/QI program. What does this do? This helps us troubleshoot issues. We identify them during the assessment, and then it helps us develop and deploy tactics like enhancements of your computer systems, staff training, things of that nature to continuously maximize reimbursement. It also can be the, you can use this for discussions with your managed care payers or maybe your Medicare, Medicaid reps to be able to ensure that all of the information that you're getting from them is being captured properly in your system. And most importantly, maintain your progress. This is not a do it once and then put it back on the shelf type of an initiative. This is something that is really recommended to be stood up in your health center and continue on into perpetuity as part of your QI/QA process. And then please keep up to date on ICD-10. And again, I've got some references for you on that end as well. So what's step one? Step one is to establish some key performance indicators, KPIs, as HRSA calls it. So first of all, establish the ones that are important for your health center to track. There's days to final bill. What does that mean? That's the days from when we actually start an encounter to the days that we can actually get the final bill out the door and to the payer. Days to payment. That's after we submit it and it's accepted by the payer. until we get the money in our bank account, or at least get the RA, the remittance advice, to state that it has been paid. Claims accepted or rejected rates. This is where some of the health centers saw an immediate shift in October because some of the private payers were being very specific and were not accepting any other coding issues even from the get-go. Claims denial rate, of course, that's once you see the claims getting through the system, so the accepted rejected is the first, if you will, the first wall that they jump over from either your internal scrub or the clearinghouse scrub. And then the denial rate is once they go all the way through the system to the payer side, they can come back and say denied for improper use of ICD-10 code. The reimbursement rate, I didn't see a lot of this yet, but again, I've got a little bit of fear that this may come into play a little bit more in the future. But this would be them reducing charges or payments based on improper coding or acuity levels, things of that nature. Coder productivity is another one. If you do have coders that actually do the matching and do the coding on behalf of the providers, this could be an interesting thing to track over time, more though as an internal performance measure, and the comfort level of your coders to be able to show that they're learning these ICD-10 code, the codes and the matching. And this is more of like the number of medical records coded per hour reviewed by the individual coder. Requests for additional information is another one, so I'm kind of skipping around here. If the coder codes it correctly, but yet it doesn't get denied and it gets clogs in the payment system, you might be getting an inordinate amount of requests from the payers for additional information required to process the claims. The next one, daily charges to claims, the number of charges or claims submitted per day. That you probably have already recovered from any sort of slowdown in this regard, but it can be indicative of the doctor perhaps not being able to code the chart properly or capture their charges because of inability to code due to them not understanding the coding that they have to get done. Or another popular way is you can monitor new physicians or new providers against some of your more seasoned providers just to kind of see if the issue is at that level, or you'll see it at the coder level or at the chart capture level as you're looking in your systems. Clearinghouse edits. This is probably the best one to be able to use to determine whether or not your charges are sitting in your batch before they can even get to the payer. Because the clearinghouse edits will come back from Availity or some of the other popular clearinghouses as denials, but it'll show as a pending claim instead of an actual denial. And so, or it'll show that they actually corrected it and sent it through, or probably what it's going to be showing right now is that other that I was telling you about, where it's not really a denial, but it's a recommendation or a notice that in the future this claim may be denied. So you definitely want to look at that KPI and make sure that that hasn't shifted between October and now. And then payer edits, again, the reasons for the edits. The use of ICD-10 on prior authorization referrals. Okay, so this is another important one to monitor for the front end of the system, because if your authorization process did not formerly require the proper codes, and then all of a sudden it does start requiring them, it's important for you to understand that operationally, to be able to ensure that you're doing it at the front end, and you can communicate with your front end staff to be sure that's getting done. And then last but not least, another one, use of unspecified code. Sorry about that typo, I'll fix that before we send out the final slides. what this means is unspecified codes. There are certain codes, even in ICD-10, that are unspecified, believe it or not. Even though I know we're going to the highest level of specificity, you can go through for your specific types of providers, and I've got some specialty resources I'm going to share with you in the next couple of minutes that actually list some of these, and you kind of see them in the code book as a do not use flag, kind of like we saw in ICD-9. But you definitely want to monitor the use of these, but even to that level, you also want to monitor the frequency of some of your codes with regard to perhaps some of your most problematic matchings, and that would be any of the chronic diseases are going to give you some issues. Hypertension, diabetes, those types of things are going to give you issues, and you should now see, instead of the coding approaching the mean and not being a good distribution, what I'm saying is you should see more codes being used less frequently rather than just a very few codes being used very frequently. That's another indication that you're not really using the most specificity or the best code perhaps for that particular encounter. So let's talk then about how, so you decide for yourselves which of these you're going to monitor and how many you can monitor based on what I'm about to discuss. The ICD-10 baseline can usually be seen in some of your old reports in your health center. So examples may be some provider reports that you used to put out with regard to claims denials and things of that nature. Some practices or some health centers actually put out reports on their front desk staff and how many of their claims or their pre-authorizations or their eligibility checks actually don't go through. So you can look back and see if you have any of those types of resources and then try to adapt them to the new environment with the ICD-10. You may also be lucky enough to go back and mine data from your management system. A lot of the practice management systems have left intact the ability to go back in time and use ICD-9 information to pull some of these productivity reports on these KPIs. Some have not, unfortunately. So check with your practice management vendor to see if they're able to do that. And again, once you decide on which ones you want to try to track, you can go back and try to get those reports. One caveat I would recommend is that if you do that and you're not using the exact same report that you used for ICD-9 and now using it for ICD-10, that you do a little bit of work around validation of the results of those two disparate reports, because you may have some issues there as well that don't really indicate ICD-10 issues, they're reporting issues. That's just a caveat for you. Another one that would be really good, the claims clearinghouses can give you some background and some prior reporting on pre-ICD-10 implementation. They can give you, of course, usually that revolves around the things they handle, just your claims acceptance, rejection. Most of them will pass back through the claims denial rates, although that's a little more problematic because you don't really get every single denial back through the clearinghouse. Some of them come back to you on paper, as you know. But at least some of the productivity questions you may be able to get from there. If you are with a very big insurance plan like Blue Cross or some of the other big ones that constitute a major portion of your income, you may also ask them for some claims denial history reports. And then your system vendors, sometimes they keep monitoring on your performance. That's usually some of the computer systems that are inside of HCCNs or some of the big healthcare controlled networks, health center controlled networks. But you may ask your system vendor if they do keep statistics on the performance of their clients' practices. So once you decide what KPIs you're going to look at and which ones are important to you, your board members, and the success of the implementation of a strategic plan, again, consider that 360 analysis as part of this. Review the reports. Create some sort of an ICD-10 feedback data system where you can track the history, establish, which is your baseline, establish where you want to be, your benchmark, and then have some sort of an easy method to reflect that information in some sort of an operational dashboard to show whether you're meeting those or not, and then the movement of those metrics over time. And continuously report this to the QI/QA committee. Many highly performing health centers actually use the QI/QA process on financial and operational metrics as well as clinical metrics, which we're all used to doing this on the clinical side. So I'd highly recommend you use it for that perspective as well. So addressing your findings. So once you've got some sort of a trend that you can identify, and then you dive in and see what might have been causing it, you can assess things that you might be able to do to improve your organization and make your process a little bit more solid for the future. Are there differences in documentation structure or required content? Are the vendor templates changing? Did they change them or did they not change them? Did they make you do workarounds? And then a lot of people will look at that 360 and look at the charge that went out and then look back at the record that they actually had that supports the diagnosis coding and the procedure coding, and did that record really support the submission of that charge as it is? Another important thing is to understand who does what in your practice very specifically and engage them on this. Who does your diagnosis codes? Who selects them? Who ensures the codes are appropriate and compliant with all of the various and sundry billing requirements that we're under? So these are three resources, all CMS based, that I would highly recommend you look at. And again, you're going to get a copy of this, so don't try to write this down right now. But this is the website you can go to for CMS for a good overall view of ICD-10. And a best practice is just click on it once a month and see if anything's new. There's a section in it that talks about new updates and news and newsworthy events. The Specialty Resources Guide is the one I was speaking of, where you can actually get in and look at specific specialties that you're dealing with in your health centers and some specific coding recommendations and guidelines and guidebooks to be able to help you code appropriately. And then, of course, the age-old coding and clinical documentation of this is more about CPT and HCPCS, but again, it's something that's well worth revisiting. Where we've got some differences now in this realm are the ICD-10 codes we place for family history, for surgical history, things of that nature. So you kind of want to go through that as well. And then, last but not least, addressing your findings, check your systems for issues. Very important. Make sure you understand, or your data person, whoever's responsible for making sure your system is performing optimally, make sure they understand how UDS handles the data, or not UDS, how their UDS reporting system handles the data bits, and how you put something in the system comes across all the way through to the UDS report. One thing I like to do is take 20 patient records and just look at their last year's encounters and diagnoses and their history and things of that nature, and then look at the UDS detail tables and make sure that that person shows up in the universe and that person shows up in the numerator. It's kind of a way to track through and just make sure that what you're looking at really flows through the entire system properly. And then last but not least, here's some other helpful resources that you can go to. And again, you're going to get a copy of this. These were all working yesterday. I tested them, but of course these do change over time. So that being said, I'd like to end the conference. I hope I've given you some useful information, and I'd like to take some questions now, if that's okay.
Thank you, David, for this excellent presentation. We are going to start the Q&A. If you have any questions, please submit it through the question box on your control panel, or you can also use the hand raise icon and your line will be unmuted. So we're going to wait for some questions, but in the meantime, I would like to announce the regional symposium that we are going to host in Chicago in the month of November. Please visit our website, www.nchph.org, where you can find information about the symposium, the workshops, and detailed information on the agenda. We are going to focus on different emerging topics affecting public housing residents and PHPCs, opioids and substance abuse, mental health, smoking cessation, and the proposed rule by HUD instituting smoke-free public housing. So once again, visit our website, www.nchph.org, and you will find more information about our upcoming regional symposium, as well as information on the national symposium that we are planning to host in the spring of 2017.
So I've got one question in here. It is, do you think having a scrubbing tool would be beneficial for an FQHC, and if so, why?
So most of your tools, most of you do have a scrubber already existent in your system, and it is definitely beneficial, because if you can scrub that claim ahead of time before it gets gummed up in the payers or the clearinghouses scrubber, it's much better, because you can actually control more quickly the correction of that, and you can program those scrubbers, or they come pre-programmed, to not learn your system, but perhaps take extra care looking at certain specialties or coding pairings that you may have specifically in your system. So I would invite you to check your computer vendor to see how that already functions in yours, and if it is something you could add, I would definitely highly recommend adding it.
Another question we have coming in is, I took some camera shots. Where can I find those now?
And that sounds like a system issue. You mean you took shots of the screen? I think, Dr. Leon, you're going to send this out to everybody, correct?
Correct.
Oh,
Correct.
okay, yes. Yeah. So you won't need the screenshots, but I'm not sure where they go on your computer. Mine normally go on my desktop, so check there.
We're going to send the slides to the attendees, and also we are going to post the slides to our website. Do you see any other questions, Brendan? I do not see any questions on my end.
I see one more. Do you have a suggestion for a good scrubbing tool if our system does not include one?
So I have not seen any independent ones recently, so I don't think I could be much help for that, unfortunately. But if needed, I could do a quick survey of information that's out on the internet to be able to help you get that. But most of the software packages, I have to tell you, are going to have that, because the initial scrub is looking for major issues like, is it missing a diagnosis code? Is it is the diagnosis code that's attached to this reasonable for the gender of the patient? Most of them start there. Some of them actually do include certain things from the insurance companies on particular pair matchings. But really, if your software doesn't have one, I don't know of one off the top of my head that's independent.
Thank you, David. Any other questions, Brendan?
Not that I can see, no.
All right. So I want to thank David for this wonderful presentation one more time. And to all attendees, please complete the post survey. It helps the National Center for Health and Public Housing to improve our webinars. If you have any training or technical assistance needs, please contact our staff. And also visit our website. You can find information about webinars, monographs provided on Residence Center, fact sheets, training manuals, newsletters, information about our symposiums, information on how to complete a training and technical assistance form. Also, join our mailing list and receive HRSA updates, Medicare updates, information on funding opportunities, information on senior programs, and information about our webinars, our upcoming webinars and past webinars. So you can also follow us on social media. You can subscribe to our YouTube channel or Twitter account or Facebook page. And once again, thank you very much, David, for this excellent presentation. And once again, I want to thank all attendees for attending this webinar. Thank you very much and have a great afternoon.